Hi, my name is Lunfa Chowdhury and today's presentation will focus on development, diagnosis and care of gestational diabetes, the development, diagnosis and monitoring of preeclampsia, and the dangers of substance misuse in pregnancy. First, let's take a look at gestational diabetes. Gestational diabetes occurs during pregnancy when the body's additional need for more insulin fails, and therefore regulation of blood sugar control is impacted, causing high sugar levels, otherwise known as hypoglycemia. This is because of the high production levels of other hormones by the pancreas, estrogen, cortisol, and humoplacental lactogen, having a blocking effect on insulin, also known as contrainsulin. As more of these hormones are produced due to the placental growth, the risk of insulin resistance also increases. The pancreas usually tries to keep up by producing additional insulin to counter this, but if it cannot produce enough insulin, gestational diabetes occurs. Gestational diabetes is usually identified during the second trimester, but can happen at any time to anyone during the pregnancy. And you are more at risk of developing it if you have had previous gestational diabetes, have a parent or sibling with diabetes, have a BMI that is above 30, are over the age of 40, are from South Asian, Chinese, African, Caribbean or Middle Eastern descent, have had a previous baby weighing more than 10 pounds at birth, have PCOS, or have had a weight loss surgery or gastric band. Diagnosis and screening. Diagnosis for gestational diabetes is through a screening test, and screening will be offered if one or more of the risk factors is identified during the first antenatal meeting. This is usually 8 to 12 weeks through a series of questions. If a large fetus is identified during antenatal exam, this may also be a sign of gestational diabetes, although not always the case. Screening will be offered. Another indication could be unusual high amounts of amniotic fluid around the fetus. Too much fluid can increase the risk of premature labour, so it's important to have this checked. Screening will be offered. Screening will also be offered if symptoms that cause gestational diabetes are present or occur. Symptoms include headaches, increased thirst and dry mouth, increased urination, fatigue, urinary tract infections, thrush, dizziness, blurred vision, or lack of balance. The screening test is optional and called an oral glucose tolerance test and carried out between 24 to 28 weeks, however can be carried out later. On the day of the test, the pregnant person will attend a clinic and have a blood test whilst on a fasting diet. No food or drinks for the last 8 to 10 hours apart from water. They will then drink a glucose drink, and after 2 hours of rest, another blood sample is taken to see how well the body has coped with the glucose. The levels are tested before and after, and someone with a fasting value of 7 mmol per L and the value of 11.0 after 2 hours will be diagnosed with gestational diabetes. Appropriate care plan for someone with gestational diabetes. Care plans aim to keep the blood sugar level within a healthy range and to avoid further complications. When a person is diagnosed with gestational diabetes, a midwife will support them firstly by giving them accurate information on what it is and how to manage it. Support also includes increased antenatal care. Healthcare teams will aim to have contact with the pregnant person every 1 to 2 weeks. Increased antenatal appointments will allow midwife to check person's health and fetal growth. Ultrasounds may also be offered to check the fetal growth is healthy. Blood glucose monitoring. The pregnant person will be advised on how to check their blood sugar properly, including when and how often to do it. Information on what blood sugar range is will also be given, and how to share readings with healthcare team so they can give the right support and treatment. The pregnant person will be given a blood glucose testing kit, which consists of a finger prick, testing strips and glucose monitor. The finger prick will make a small incision at the tip of the finger, and a small amount of blood will be collected on the tip of the strip, which is connected to a monitor, which then analyses and reads the sugar level. The pregnant person will be shown how to do this. The recommended levels to aim for are 5.3 or less before meals and 7.8 or less 1 hour after meals. These readings are to be recorded and reviewed at the next antenatal check. Dietary recommendations may also be given to support gestational diabetes. It is important for the person to understand the impact of foods on sugar level, especially foods with a high glycemic index. The glycemic index shows how fast a carbohydrate containing food raises your blood sugar. It is scored from 0 to 100 and can be helpful to manage diabetes. Lower GI foods scoring 55 or below raise blood sugar slowly and include most berries, milk, yogurt, lentils and rye bread. Medium GI foods scoring 56 to 69 raise at a moderate rate and include cantaloupe, pineapple, couscous, basmati rice and popcorn. High GI foods scoring 70 plus cause a faster rise in sugar level and include white and some wholemeal breads, regular potatoes, sweets, sugary cereals, sugary drinks and watermelon. Replacing high GI foods and drinks for slower, lower GI ones are better for managing blood sugar levels in people with gestational diabetes. Pregnant person may also be referred to a dietitian for further support. The NHS Eat Well guide may also be recommended. Physical activity will also be advised, as this will help maintain blood sugar level. In exercise, muscles use glucose, and after exercise, muscles stay more sensitive to insulin. Therefore, blood sugar levels stay lower for longer. Recommendations are 150 minutes of moderate exercise during a week, with additional muscle strengthening exercise twice a week. Medication may also be advised if necessary. This will be dependent on results and management of blood glucose level. The two main medications for gestational diabetes are metformin, which is a slow-release tablet that lowers blood glucose by decreasing levels produced by the liver, and insulin injections. These are to be injected in the stomach and may be advised if blood glucose level is not managed well through other recommendation or medication method. The development, diagnosis and monitoring of preeclampsia. Although the exact cause unknown, preeclampsia is a serious condition where there is a persistent high blood pressure accompanied by protein in the urine, and usually occurs 20 weeks gestation onwards, but can happen at any time. Someone could have mild or severe preeclampsia, or it can be chronic hypertension with superimposed preeclampsia. It causes further health complications such as eclampsia and damage to organs. Some factors increase the risk of preeclampsia occurring. A person is more at risk if they have an age of 40 years old or above, pregnancy where there is more than one baby, a BMI score of 35 or higher, diagnosis of diabetes, kidney disease or high blood pressure prior to pregnancy, autoimmune conditions, history of preeclampsia in the family, a gap of more than 10 years since the last pregnancy, previous premature birth, a history of preeclampsia and a prior pregnancy, previous pregnancy complications, obesity, and a pregnancy achieved through IVF. If more than 2 risk factors are identified, advice on how to lower the risk of preeclampsia developing will be given. For example, dietary changes, examining BI, and supporting health-informed weight loss, and prescribing a low dose of aspirin. Recognising signs and symptoms is also important, as this will aid in diagnosis and management. Some common symptoms are high blood pressure, protein in urine, serious headaches, swelling of hands, blurred vision, sudden vomiting. Less common symptoms include dizziness, sudden weight gain, difficulty breathing, reduced urination, changes in your mental state, pain in the right side of your upper abdomen, nausea, baby's growth is slower than typical, and shoulder pain. If a person feels any of these symptoms, they should get in contact with their healthcare team. It is important to note that not everyone will experience symptoms. Regular blood pressure checks are offered at antenatal appointments, so it is important to keep up with these too. Diagnosis of preeclampsia can be done in several ways. Initial alarms are high blood pressure and protein in the urine. During a person's antenatal appointment, several checks are carried out that are helpful in identifying preeclampsia. Blood pressure will be checked to examine the force of flow through main vessel. If the reading is high, further testing may be recommended. A sample of urine may also be checked for protein with a dipstick. A positive reading could indicate preeclampsia. During these visits, the fetus is also measured. If SGA, smaller than a certain age, is identified, where the fetus is smaller than it should be, may also indicate preeclampsia. Further checks may be recommended. Further checks may include urine test in a laboratory for further examination, blood test to check for protein, usually 20 weeks gestation, a Doppler ultrasound for close fetal blood flow examination, and amniocentesis, which is a collection examination of fetal cells. All testing helps confirm preeclampsia and how severe the condition is. Care plan for monitoring. Care plan and monitoring. Care plan and monitoring are planned to protect a pregnant person and baby. Once identified with preeclampsia, a person will be admitted to hospital for further monitoring. A care plan could be as follows. Watch and wait. If blood pressure is raised but not dangerously high, between 149 to 159 over 90 to 109 mmHg, the healthcare professional may choose to wait and the wait and watch approach. This means the person may be cared for as an outpatient while having regular checkups that include weekly blood pressure checks and urine tests, extra ultrasounds to monitor fetus. Further blood tests may also be carried out to assess kidney function, blood cell count, electrolyte level, liver enzymes. The aim is to see whether blood pressure is stabilized on its own or further treatment is needed. Lifestyle advice may also be given, such as following the NHS Eat Well guide, reducing salt intake, and drinking around 8 glasses of water a day. Healthcare professionals may also advise medication if the blood pressure remains high. Medication may be prescribed to help lower it. Medication prescribed depends on the person's overall health and current medications, allergies or intolerances, side effects, and personal preference. Medications include labetalol, nifedipine, and methyl-dopa. The blood pressure medication is usually continued until after the baby is born and blood pressure returns to normal. Healthcare professionals may also advise birth as treatment. The only cure for preeclampsia is giving birth to baby on placenta. Decisions about timing depend on how severe the condition is and how far along the pregnancy is. So before 34 weeks, close monitoring will continue. Medication may be given to help with blood pressure, and plans for possible early birth are discussed. Between 34 and 36 weeks, monitoring will continue. Medication can be given, and early birth may be considered and recommended if blood pressure cannot be controlled, signs of problems present in the liver or kidney, or other medical issues present, or symptoms such as headaches become worse. From 37 weeks onwards, birthing is recommended within 24 to 48 hours of diagnosis. The health of the fetus may be closely monitored using heart rate monitors, ultrasound, and amniotic fluid assessment. After delivery, preeclampsia usually improves and blood pressure gradually returns to normal. The parent and baby may need to stay in hospital for a few extra days to ensure recovery is going well. Monitoring may continue for 6 to 8 weeks after birth for signs of postpartum preeclampsia, a rare condition where symptoms similar to preeclampsia appear after delivery. Postpartum preeclampsia is treated using blood pressure medications and magnesium sulfate. It is uncommon, but awareness of symptoms ensures right diagnosis and treatment is carried out. The impacts of preeclampsia if left untreated. Preeclampsia is a serious condition, and if left untreated can have a huge impact on the health of the pregnant person and their fetus, and possibly be fatal. For the pregnant person, preeclampsia could cause eclampsia when seizures occur, placental erosion when the placenta can separate from the uterus too early, causing heavy bleeding, HELLP syndrome, which is hemolysis or destruction of red blood cells, raised liver enzymes and low stellate count, and can affect several organs, organ damage, heart disease risk, stroke risk as well, and blood clotting problems. The mother's blood clotting system can stop working properly. This can cause heavy bleeding or dangerous clots to form that can block blood flow and damage organs. Preeclampsia could affect fetus as oxygen and nutrient supply is reduced. Baby's growth can slow down, otherwise known as intrauterine growth restriction, and cause premature birth. In severe cases, low oxygen levels can cause a condition called lactic acidosis. When oxygen is low, the body will prioritize blood towards brain and heart, reducing flow to other organs that can then build up lactic acid, leading to loss of movement or unconsciousness. This is a medical emergency and may require early delivery. In some rare cases, eclampsia can occur from severe preeclampsia and may be due to genetics, hormone imbalance, blood clotting, or other changes within the body. The person can be more at risk if it is their pregnancy, under 17 or over 35, having a BMI over 30, or diabetes, kidney disease, or autoimmune condition. Eclampsia occurs after 20 weeks of pregnancy but can happen anytime during or after birth. It is a serious condition where high blood pressure affects blood vessels in the brain, causing swelling that can trigger seizures. During a seizure, the body may become stiff, shake uncontrollably, and lead to loss of consciousness. Warning signs may include severe or persistent headaches, blurred vision, trouble breathing, little or no urine output, sudden swelling of the face, hands, or ankles, nausea or vomiting, and facial twitching. Eclampsia is treated by stabilizing a person and then delivering baby. The first step is to control seizures using medication and magnesium sulfate. Blood pressure is closely monitored, and once stable, labour may be induced. And it's common to give birth by caesarean section, but some people can opt for vaginal delivery. The risk of consuming alcohol during pregnancy. Alcohol consumption during pregnancy can impact fetal growth and development and can cause complications during and after birth, so it is recommended that intake is reduced or completely stopped as a preventative measure. Consumption of alcohol can lead to premature labour. This is when a baby is born early, before 37 weeks, and will require additional monitoring as they will have not yet fully developed. Pregnant person will also need monitoring. Akira notes that alcohol may induce preterm delivery through increased secretion of prostaglandins, which enhance uterine contractions. The higher the intake of alcohol, the higher the risk of premature birth, stillbirth, and miscarriages. Risk to fetus. Alcohol is a teratogen, meaning it impacts normal fetal development. When consumed, it gets absorbed by the bloodstream and passed through the placenta to the fetus, where the liver is still not fully developed and unable to process or break down the toxins in alcohol. This has several impacts on the fetus, including fetal alcohol spectrum disorder. Alcohol can disrupt normal brain development, leading to many future issues. Individuals with fetal alcohol spectrum disorder may have cognitive difficulties, issues with motor skills, issues with developmental function of joints, muscles, or bones, impulse control difficulty, physical abnormalities, and sensory issues. Alcohol can also cause small gestational age, where the fetus is smaller than it should be, and it can lead to miscarriage or stillbirth. It can also cause low birth weight when a baby is born under 5 pounds and 8 ounces. Alcohol misuse during pregnancy can contribute to this, and a baby with a low birth weight can develop the following issues: breathing difficulties, low blood sugar levels, being overly cold to the lack of fat layers, and difficulties in eating or digestive issues. The impact of illegal substances. The use of illegal substances or drugs can have severe impacts on pregnancy and fetus. Drugs pass into the bloodstream of the fetus through the placenta, which can cause complications for pregnant person and fetus. Use of illegal substances can cause premature birth, miscarriage, or stillbirth, and low birth weight. The table below highlights some drugs and potential risks and impact. For example, ecstasy can cause birth defects. Drug use can also impact baby at birth. When drugs are used, dependency occurs. This can also happen to your baby when the umbilical cord is cut. There is no longer supply of substance to the baby, and this can lead to a baby having withdrawal symptoms. This is known as neonatal abstinence syndrome, and symptoms can include sneezing, tremors, irritability, increased muscle tone, disruption in sleep and rest, fast breathing, and lack of weight gain. After birth, if there are signs of NAS, baby may need to move to neonatal unit for further monitoring and support. Some support may include medication given to help newborn wean off from their dependent drug, and this can take days or months. The safest approach would be completely stopping the use of any illegal substance. Help can be sought from healthcare professionals, antenatal and family support service, or drug treatment services. We have covered gestational diabetes, preeclampsia, alcohol, and illegal substance use. Understanding each and identifying symptoms and being aware of impacts is vital for healthy pregnancy and healthy fetal development, and following correct care plans where necessary. Thank you.